We have a quiz question. It is to be answered during the presentation. Which sentence about autoimmune pancreatitis type 1 is incorrect? A, it is characterized by the presence of EGG4 at the involved site. B, the involvement of other organs is present just in 10% of the case. C, the focal form is less common than the diffuse form. D, steroids represent the first line treatment. And E, jaundice could be the first symptom.
And the talk I was given was to discuss with you the role of EUS in unexplained acute pancreatitis, when to perform EUS and what to look for. The objectives are that I try to convince you of the added value of EUS in diagnosing the etiology of unexplained acute pancreatitis, both in acute setting and after healing of the acute pancreatitis. The scheme of my talk is first reveal what we mean by unexplained acute pancreatitis, and then a word on when to perform and what to look for both in acute setting and after healing of acute pancreatitis. Yes, and here you start to see this hyperechoic mass, really quite clear here, which we are puncturing and which on elastography is very blue, so suspicious of a heart lesion, which was a tumor. Some days later, patient got a staging CT, which was confirming the diagnosis. Here you have it, of a tumor which was provoking 1 month earlier the pancreatitis.
And this is another nice case, I think. 63 years old male. The onset is jaundice, and MRI show a double duct sign. So stenosis of the bile duct, but also the main pancreatic duct. This is the mass, and this is the CBD with stenosis here. But again, you have to look all the patient. The bile duct is thickened here, and also into the liver, the bile duct has thickened wall. And also the main pancreatic duct, you see, is like a sandwich pattern here with a virtual lumen that go into the mass. And we did contrast again. I think it is really useful. This is the main pancreatic duct. And if you look at the mass here, you see it is not clearly hypovascular. There is a quite good uptake of contrast. So our suspicion moved from cancer to probably autoimmune pancreatitis. So the message is that you have to think that a patient can have autoimmune pancreatitis.
It's mostly something related to the ERCP practice when we have like autoimmune pancreatitis that at the onset with jaundice. To stent or not to stent? This is the question, huh?
It's a really good question. Of course, it depends on the level of bilirubin. If you have 20, you have to stent for sure. But if the diagnosis is not clear and you have 2-3 milligram of bilirubin and you suspect on EUS that can be an autoimmune pancreatitis, we usually do not perform ERCP and wait for diagnosis. So I think this is the strategy. You have to, but you have to think again that the patient can have an autoimmune pancreatitis. If you think that is a cancer, you go for ERCP. But again, the message is to not put an uncovered stent, but always a fully covered if you do not have the diagnosis.
Thank you, Stefan.
I think it still remains a very challenging diagnosis.